today I've been tasked with talking about stuff about the RV. I think we sort of cycle back through the standard DDU, well, not quite standard, DDU curriculum to try and come back for the new people that are joining the group and going to be getting ready for their DDU exams and perhaps the ASE exams and whatever other fun things people are venturing down the road of, EDEC and that sort of thing, for example. So the purpose of today is to, as you can see from my title slide, sort of flick through some stuff to do with the right ventricle. It was originally sort of going to be cases and be some physiology, and I couldn't really come up with a great title for it overall. So I just thought I'd call it RV stuff. And then I thought I'd let Sam and Tara and whoever else does all the YouTube stuff to sort it out from there. Ask questions along the way. I've done a classic Emma Bocock and gotten like 70 or 80 slides for something that is going to be far shorter. So I'll probably end up stopping halfway through. Crack on. So this is what we're dealing with, right? So we're dealing with the right side of the heart. Now, I'm a respiratory physician for those of you that don't know, and the lungs are the most important thing, but there's a bit of heart on either side. And the reason that the right heart is, I guess, sort of underrated at times is because it doesn't pump to the systemic circulation, historically been ignored, as we all know. I won't labor that point. But the reason I think it's important as a respiratory physician is because it oxygenates the most important organ in the body. Well, sends blood to the most important organ in the body, I should say. Yes, there's the bronchial circulation, but that's minor unless you've got significant hemoptysis, and that's pretty rare. So the right ventricle is more different than similar to the left ventricle. I know this is an echo-based sort of teaching program. I promise there's some echo stuff coming, but I think this is important to have an understanding of the foundation as to why things work differently. So the RV is not just a mirror image of the LV. From the start, it's different. Embryologically, it's different. The muscle fiber and the pattern in which those muscle fibers are laid out is different, so it contracts in a different way, which makes assessment by echo a very different process to assessing the left ventricle. It has a different response to medications that are given. So it has a different afterload, so it needs less energy to do a certain amount of work. So that's reduced by about 20%. It's got a different oxygen extraction ratio, so the tissue itself will take out a different amount of oxygen as the blood goes through it. So it's got more like reserved there. The left ventricle will take out about 75% of the oxygen from the blood that goes through the coronary arteries that go to it. The RV is on about 50%. And it can typically get a greater proportion of the cardiac cycle with which it itself is oxygenated. It's different even down to a metabolic gene profile. So it will deal with energy substrates differently. One of the consequences of it being different to the LV is that it is more likely to become fibrotic when it has volume overload compared to the LV, which is very important because we get this, a chronically failed RV can be a fibrotic RV due to that ongoing volume overload. And then the treatment, as we all know, for RV failure is very different to the standard LV failure therapies. A lot of the medications that are thrown into the outpatient style failing LV, beta blockers, depending on the case, of course, ACE inhibitors, angiotensin receptor blockers, spironolactone, all those sorts of things, SGLT2 inhibitors. The evidence for those in the right heart is different to that in the left heart. And by different, I mean non-existent. This is an online tool called Harvey. For those of you that haven't seen it, I strongly recommend having a look. I bought one of the cheaper subscription to it. I think I pay like $50 a year or $100 a year or something. It's very useful because it lets you go in and you get a screen like this and you can put in different disease states and you can change all these parameters and you can fluid load people and you can see what happens to their invasive hemodynamics. And the purpose of me showing this is to show that whilst the right and the left ventricles sit side by side, they function very differently. They run at a different volume or different volume pressure curves. So you can see the shapes of things are profoundly different. So here we've got volume here on the x-axis and pressure on the y. You can see how the right ventricle functions as a much lower pressure compared to the left ventricle. Have a play with it. It's an amazing tool. Go and have a look at it. All right, a bit of the echo stuff now. So when we're looking at right ventricular function on echo, we can look at it, or way you can conceptualize it is you can think of regional function. So that's our tricuspid plane, systolic excursion, or TAPSE. We can look at our tissue velocities, or S primes, our systolic tissue velocity. You can eyeball the right ventricle and you look at what its segments are doing, other segments functioning appropriately. Not something we do commonly or as commonly on the right compared to what we do on the left, but we do that too. There's global function, so fractional area change. We've got strain, which is becoming more and more important, or more and more evidence-based, I suppose. There's myocardial performance index, and I've got a picture of that there on the right just to show what that is for those of you that don't know. You can absolutely do DPDT like you can do with the left heart using tricuspid rather than mitral regurgitation. And then there's volumetric stuff that can be done from a 3D perspective. Last of all, there's eyeballing it, right? And this is something that I think we'll probably all do. So we'll all eyeball it, we'll all have a bit of a thought. We incorporate the numbers like TAPSE, we'll incorporate FAC if it's been done. No one ever does myocardial performance index, even though there's a bit of evidence for it, to be honest. But then ultimately we sort of look at the right ventricle and say, does it look like it's functioning right? Now, whether that's the best way to go versus whether that's what's actually done in the real world, you could argue that it's not. But at the end of the day, it's what a lot of people sort of incorporate into their practice, and they think about it in the clinical context of the patient. What's their volume status like? What drugs are they on? All that sort of stuff. Last of all is coupling. Coupling is really important. So coupling is really that energy transfer from the right ventricle to the pulmonary circulation. It's a relationship between it, because if you've got a strong right ventricle, but the resistance it's facing from the pulmonary circulation for whatever reason is greater, then you can you can lose that relationship, you can lose that coupling. So then no matter how well your RV is functioning, if it can't get blood through the circuit and do the job it's meant to do, or if the energy cost for that is so high, then it becomes a dysfunctional circuit, irrespective of what some of your sort of single point parameters are doing. There are different ways to look at coupling. So I've listed two here, which is TAPSE over pulmonary systolic pressure, or RV free strain over pulmonary systolic pressure. If you look through different literature, you'll see it being done in different ways. But at the end of the day, it's all about taking a measure of RV function, so TAPSE, for example, and putting it over a measure of the pressure it's going up against, so pulmonary systolic pressure, coming out with a number, and then where that number lies with respect to where it should be in health is what people do. So this is a big list. Again, I took this from a Journal of American College of Cardiology article, I think, from 10 or 15 years ago. It just sort of summarizes it all, what their normal ranges are, how load dependent some of these parameters are, and then really if there's any evidence for it. I have to say that what they call their IVA, or the maximum velocity over the time to peak velocity, I'd never heard of that before. When I was preparing for this, it's quite interesting to see that, because they say it's actually a relatively load independent measure. So again, not something that I've ever done, not something that I've ever heard about before. I don't know what the evidence is. Here from this paper from 10 or 15 years ago, I talked about it being a promising new non-invasive index of contractility. This is in congenital heart disease. I've not seen it come out since then, so I'm suspecting that the evidence probably fell through a little bit, but it's another one that's there. I can't have a talk on RV stuff without going through a bit of the segmental anatomy. So these are the walls of the right ventricle, as opposed to learning the 16 odd segments of the left ventricle. It's much more simple on the right. There's a lateral, there's an anterior wall, and then there's an inferior wall. And the image down the bottom here, whoops, what have I done there? There we go. Image down the bottom is just to demonstrate where everything lies with respect to the interventricular septum. I don't think this has a whole lot of clinical relevance, to be honest. We talk about it when we say it's this wall or that wall when we're looking at the pictures, but overall, it's not something that's used very commonly, at least in my practice. So a quick slide. I think I've only got one slide actually on RV failure before getting into some pictures and a bit more detail about later on. So conceptualize right ventricular failure, even though the definition of what RV failure is can be hard to pinpoint, as being either acute or chronic. So acute is when it can be a quick onset, and either be from a heart that was completely normal not that long ago to a heart now that is horrifically functioning horrifically poorly, or it can be in the setting of underlying chronic RV dysfunction. So acute is when it gets bigger in size because either its afterload or its preload's gotten better. You think of the Starling effect, stuff we've heard of before. Chronic is also referred to as the NREP effect, if you come across that. So in the setting of chronic right ventricular overload, it will start to pump stronger. Okay, so it's a bit like the RVs going to the gym all day, every day. Increased loading, so it gets stronger and stronger, which is great. It has to do that to keep up its function, right? To keep up that coupling. It's got more resistance. It needs to be stronger to pump blood out. But then what can happen is when that becomes maladaptive, you have a heart that is doing that, and it then gets volume overloaded, or it then gets septic, or it then gets tachycardic, or it then has an RV infarct or whatever. You change ventilatory parameters because this person gets intubated because they've got lung disease. Then all of a sudden it can't cope, and so you get an acute on chronic RV dysfunction. All right, I'm going to run through a few cases now. Some of you may have seen these cases before. I've sort of presented these at various time points over the last year or two. So I'll pick someone who's willing to talk. So this first case, 39-year-old bloke, he's got idiopathic pulmonary arterial hypertension. He's on all the good stuff for that. LTOT is long-term oxygen therapy. And he comes in with acute respiratory failure. So he's on a fair amount of oxygen, FiO2 60%, 50 liters of flow. He's not decompensated from a respiratory acid base status. CO2 is only 40. Let's have a look. So, Rishi, do you want to tell me what you see?
Sure. So looking at the images on the top left, first on the long axis view, the most obvious abnormality is a slightly dilated, I would say, dilated RVOT with reduced contractility, possibly with thickened, but that needs to be confirmed with other views. LV function appears normal and with normal size. There appears to be an interventricular septal wobble, which is also apparent in the western short axis views.
When you say what do you mean?
The interventricular septal is bouncing.
Yep.
On the RV inflow views, the right, there appears to be a trace to mild tricuspid regurg jet based on just on the color jet, with an optimal color gain. Along the short axis windows, I'm not sure why we have multiple valves. I think we can see in the bottom left, there's a portion of the tricuspid valve coming into the picture.
Yeah.
Not sure why the color window is focused there in that's not a classic view. But the obvious feature is a dilated right ventricle, thickened, and interventricular septal flattening, which appears to be in systole, which probably I need to confirm it by pausing it and slowing it down.
Yeah.
Drag the slider. But to me, it looks like it is in systole, which is evidence of possibly a pressure overloaded ventricle. So overall, all in all, looks like someone having a chronically overloaded right ventricle, which has adapted to it with hypertrophy and dilatation.
And what's this structure here?
Can't see your pointer.
Moving up through here, it's on the top left image.
Oh yeah, that's a very prominent trabecular band as well, moderator band, sorry, which is also supportive of hypertrophied right ventricle.
Yeah, good. I mean, it's an obvious finding, right, when you know what to call it. And what are the walls of the LV you can see here, just for funsies?
So we are looking at the anteroseptal and the inferolateral wall.
Yeah, good. Stop there. Let's move on. Actually, before we move on, what do you, in light of what you can see just from these four images, with respect to the tricuspid regurgitation here, do you think that is an adequate representation of what this patient's TR is going to be? Or do you think we're missing it? Or do you think there's something else going on?
I mean, the right atrium looks a bit dilated to me. Whether there is a rapid pressure equalization that could explain a bit of lack of adequate, like a strong color jet, but we'll need to run a Doppler waveform through it, continuous wave, to see the profile of it,
Very good.
to see what's going on.
All right.
So that's more obvious now. Looks like a severely dilated and hypertrophic right ventricle with prominent right ventricular hypertrophy and papillary muscles to moderator bands.
Mm-hmm.
Um, Along, this is slightly off axis. I can't see the tricuspid valve opening well. On the top right, I can see the tricuspid valve opening well. Appears to be opposing well. There doesn't appear to be any structural gap on it, but severely dilated right atrium and right ventricle, along with about features of right ventricle hypertrophy along the on the 2D image. Again, on the color windows there appears to be a broad jet, um, and which really I need to interrogate a bit more with continuous Doppler waveforms. But I'll be suspicious that there could be an elevated right atrial pressure, which could preclude a massive jet, which we can see.
Yeah, I mean, your right atrium is massive. Your right ventricle is, clearly long-term changes with the extent to which it's trabeculated.
Yeah.
Um,
And I should comment on the function as well. I think it looks like it's got severe right ventricular dysfunction as well.
yeah, it's all like hunched over, bent over sort of right ventricle. It does not look to be coming in very much at all through here. So there's a bit of, I guess, base to apex sort of bouncing movement of the annulus. So you can put a M mode cursor through there. I'm sure you'll see a bit of movement. I'm sure your S prime won't be, it's not going to be zero. It's not going to be horrifically low. But I think if you just look at this regional function of this, if you're just looking here, then you're going to potentially overcall what your true RV function is when you incorporate the whole thing. Like your FAC is going to be very low, right?
Yeah.
Yeah, I appreciate we've got color over this image down here in the bottom right. And so the color can make it a bit challenging to interpret. But do you think there is good coaptation between the two leaflets you can see of that tricuspid valve leaf, like tricuspid valve?
No, I think there could be a gap in it. And this could needs a better imaging with the alternate imaging modality. But on
Yeah,
the TT, looks like the nature of the jet
yeah.
looks like quite broad based. So I'll be worried about whether there is lack of coaptation, which could also be guessed by the dilatation of the annulus, which could prevent the coaptation.
Yeah, exactly. Like, yeah, I'm glad that you're ragging out my pictures. It's appropriate thing to do. No, I agree. So I think that I would expect there to be a much greater degree of coaptation at the midpoint there when they're closed in, during systole. I think that what you can see is not. At this point, I wouldn't call it a failure of coaptation. I don't think it's that. But I would expect there to be more crossover of the two leaflets that are in view here. Let's move on. Here we go. Some of the things that you asked for.
Yeah.
So just to have to catch your eye, S prime of 9.8, TAPSI of 17, TR that tracing. What do you think of these three still images plus the IVC, of course?
Yeah, IVC is dilated and it looks like there's no respiratory variations. The tricuspid, the some of these numbers are all reflective of the longitudinal function of the RV, but as we are talking about in the last image, we were expecting that the lateral movement contraction would be less, so the fraction area change would be less, which together with my eyeball assessment, I will take that more into account, into giving a final verdict about how is the function of the right ventricle is.
Yep.
Yeah, and the IVC, I would like to measure it, but looks like at least 2.5 to between 2.5 to 3, but needs to be measured and also needs to have a color flow through it and through the IVC as well as the hepatic vein to see if there is any reflux or regurgitation of the blood back into the IVC and hepatic veins during systole.
Yeah. And what do you think of that TR where the cursor is being put there? Do you think that's a fair place to put that point, call it a maximum velocity of 3.1? or do you think there's
Yeah,
enough
that's
white
I
space here
agree.
to run the
I
truck
agree.
through?
I should back the image a bit more.
You should. I can't. I want to say I didn't take this one. Maybe I did. I can't remember.
Yeah, it's not a trace which we can accept. It's definitely there's the jet is missing.
Yeah.
There's no uniform envelope of the jet. It
Yeah.
appears adequately optimized in terms of the baseline, but I think we are missing a major chunk of the jet, which is also goes in correlates with our previous image where it showed a more broad-based jet, which will preclude us to have a very high severe velocity to begin with.
Yeah. And one of the reasons I love this case, right, is on those images that we saw previously, like it is a horrific looking RV. It is massive. It's heavily trabeculated. It looks like it's barely moving. If you were to calculate its ejection fraction, I suspect it'd be quite small. Yet you look at the conventional measures that are used in virtually at least every older fashioned echo paper about talking about right ventricular function, and TAPSE is 17, which is normal. RVS prime is greater than 9.5, which is often typically considered normal. So just if you just look at the numbers, you just look at a few select
Yeah,
images, you can call this as a normal RV, right? And it is anything but. Uh, so we've got longitudinal function is reasonable. So that's our velocity S prime and distance is our TAPSE. And I call that the interventricular segment was flattening in both diastole and systole. But I take your point, you said systole, slow it down. Might change things. So this is a chap that's come in knowing PAH and knowing, high right side pressures. He's got respiratory failure. And the question is he in respiratory failure because his RV's dropped off the cliff? Is he wet? Has he retained too much fluid from whatever reason? And does he need diuresis to pull that RV back or not?
yeah. And this is where, in my practice, I use, especially in cases where there is ventricular flattening in both systole and diastole, a combination of left atrial pressure, lung ultrasound, and VEXAS to guide my diuretic management.
Yeah,
So
very
exactly,
nice.
and what's my endpoint?
Very nice. I mean, VEXAS is, as you know, of course, to talk unto itself, probably more than one to be fair about it. Not to mention lung ultrasound, again, completely agree there. But the idea of, do I need to get this person direct to pull them back off the cliff? Are they in acute on chronic RV failure, or is their RV doing well enough to hold things? And I have to think about other causes. Is there some ventilator settings that you're using that is worsening this, and can we back off on peak, for example? That's, to try and tweak things out a bit. I like this example of, RV failure, acute on chronic or just chronic in this case.
And just to Ben, with the RVPA coupling, what would you say in this case about this one? So I had a bit of doubt on this RVPA coupling.
So for that last case, first, so I would say that I would want to see a true TR velocity to have a better understanding of what's happening within the pulmonary circulation. I think that if you had to use this case and you're going to use TAPSE where the value comes out as normal, which is probably not truly representative of what RV function is, right? You put TAPSE over that number,
Systolic pressure,
3.1, yeah. So I think that I think if you were to use a more global measure of RV function, RV free wall strain, for example, and you were to put that over an accurate representation of what their pulmonary artery pressures are, then I think you demonstrate that probably trending towards being uncoupled. But I think that if you were to use the numbers that you were given, like that we generated, right, just with this, with their TAPSE and with that sort of guess in the dark about what their pulmonary artery pressures are, I don't know how to interpret that. I don't think that either our numerator or denominator of that equation would be accurate, right? So I think in that case, coupling is a great measure. It's a functional measure, but it's only as good as the data you can put into it. And if you can't get good data to put into it, in my opinion, you can't get good data to generate that, then I think that can lead you down the wrong path, which I think we're all been guilty of in the past, right? We're only as good as the data we put into these things. If we don't have good data, that doesn't work. So this is Harvey again. So this is in PAH. Let's restart it there. So here's what happens, right? We have our right ventricle that's functioning out here. Our volumes are volume overloaded sort of right heart. Pressures have definitely gone up, of course, but it doesn't just affect the right heart, it affects the left. Through that, we've got interventricular dependence, and we've got some pericardial constraint as to how the ventricles can move, which you see in what the interventricular septum does. So it doesn't just affect the right heart, it affects the left heart as well. So RV dysfunction will affect LV dysfunction for a variety of ways, not the least of which is the pressure volume interrelationship between the two. Case 2, it's one of the few people I've ever seen that has had a tricuspid valve replacement. I don't see that very often. I think if there's anyone else that wants to volunteer, I can only see one face, and that's Rishi's. Oh, hello. We have.
Hey Ben, I'm Lucas. I'd be happy to volunteer, albeit I'm pretty early on in EDEC.
Welcome. Oh, and EDEC as well, just to make things more interesting. Sweet, man. Welcome. I don't recall having met you before. I apologize if we have.
No, we haven't. I'm up at John Hunter Hospital, one of the fellows up there. So I'm friends with Damien. I don't know if you know him. I think he's been involved in a couple of these as well.
Yeah, and from Nepean, and one or two people have gone from here up to there as well. In there.
Oh yeah. Yeah. Beck and Desh.
Beck and Desh are up there.
The Jeff as well.
Yeah. So, yeah, exactly. Yeah. Well, welcome. No worries at all, mate. So it's all about start simple, and I'll keep things very simple because that's the best I've got, to be honest. So this lady, there's her medical history. So not only has she had a dodgy tricuspid valve, which was replaced originally and then redone in 2019, she also had a pulmonary artery embolectomy for her CTEF, and she smokes a bit. So absolute cracker. So this is, just tell me what you see.
Yeah, so looking firstly at the image on the left there, it's a parasternal long axis view. So look, we've got what looks on eyeball to be a dilated RVOT up the top there, and probably would say that the left ventricle maybe is a little bit proportionally larger. The left atrium a little bit proportionally larger. Looking at the function of the left ventricle, then it would appear to be, I would say, moderately decreased, although it's global. I don't think there's any wall motion abnormalities on that particular view that I can see there. And then looking at your zoomed in sector on the right, so that's
so what the purpose of this is, what's this?
That's going to be part of the apparatus of the tricuspid valve.
And why is it that color?
Because it's got a lot of fibrosis around it potentially, and calcification. And
some of it's going to be like the only phrase that jumps to mind is sewing room material, when it's not that. Some of it's going to be artificial and bioprosthetic, right? She's had a couple of pranks around with it. That's all from there. All right. Tell me what you see here.
So on the top left, you've got a RV inflow view. So that's looking across that by the mitral valve, which was done as transcatheter replacement. So there's trying to time it. It looks like there is a degree of stenosis, like there's a firm inflow jet, if that's what I'm seeing correctly there. So
see.
What else?
So where's that? Is that showing? So that's just at the very start of the QRS. So back a bit there. That's just after the P.
All right.
Yep.
And so moving across to parasternal short axis at the level of the mitral valve, you can see again a really there's the dilated right ventricle, the septum importantly, so that does not appear flattened throughout either diastole or systole. And then looking at your continuous wave and then a pulse wave. So that's so the continuous wave on the bottom there, looks to be across the tricuspid valve.
Yeah, absolutely.
So that's
yep.
that's an inflow. Obviously, it's a really dense, like the envelope looks to be well defined and has been well traced. So in terms of what to make of this, so that's going to be pressure across that valve.
When in the cardiac cycle?
So that is in pardon me.
Yep. Yep.
Yeah, diastole, yep.
Yeah. So this is what you picked up at the very start of my here. Right? This is getting our gradients across our valve, inflow gradients into the right ventricle. So is there stenosis of that prosthetic tricuspid valve? Not something we think about very often, right? Like how often do you come across tricuspid stenosis? You think
very rarely.
Yeah, like you can think of some of the carcinoid tumors and stuff, but otherwise, yeah, maybe rheumatic. Tricuspid stenosis outside of congenital, congenital tricuspid stenosis and atresia and things, different issue. If they survive to adult and they've still got gradients, either been, intervened on, or they're very, very lucky. But yeah, so this is just seeing whether she started to clag off her prosthetic tricuspid valve.
Yeah.
And this is a crap image. You can't see at all where the gate is. It just looks to be in a big blob of grey. So this is just to see what the RVOT
VTI of 8.5.
Yeah, exactly.
Okay.
It's impossible to interpret that little thumbnail there otherwise.
Yeah.
And so I think the interesting thing here is if you look at this and you think not only is there a whole lot of turbulence, right, a heap of turbulent flow, it really starts to almost have what you nearly want to call a pisodome, right, as it comes in through here before flowing in.
Right. So, and starting in the top left, we've got a apical forward chamber. Just looking at the shape of the heart, it is pretty football shaped, and I don't know whether that's going to be a chronic change or not, but obviously we look like we're at the apex, but everything's quite round. So
you got to think about how badly am I off axis if the heart looks that round, right? How out of plane with the true axis of the left and right ventricles am I? Assuming it was made through the pictures, it probably was.
So that said, like we can see most of the structures that you want to see in this view. We can see tricuspid and mitral. We can't really make out the lateral wall of the left ventricle, but the impression is that you've got both reduced, right ventricle and left ventricular function is moderately reduced there. So, and then we've done a tissue Doppler down the bottom.
Yep.
And
number is 5.
Okay.
It's in the top corner. The number is 5, and then TAPSE, the number is 1 or 10. Yeah.
Yeah. So that TAPSE is appalling. If we think that's accurate, I don't have the RVS prime normal ranges on the tip of my tongue. I'm sorry. But...
So 9.5, which is a bit randomly obscure, depending on how much literature you want to look at. But the latest ASE guidelines from memory, and Rishi, you'll probably know them better than I do. 9.5 below that is definitely abnormal. Sort of 9.5 to 12 is probably in reality abnormal, but the lower cut point is 9.5. So that's the number to have in your brain for exam purposes, for example.
Okay. And then in your top right is just a zoomed in picture of the valve, and
I was just trying to see really what the motion of this thing is going to look like within the limits of what you can see, which she's not an easy person to image this patient.
Yeah. Certainly looks like there's a fixed structure that's protruding into the RV. I don't know how much. Yeah, that's it.
Yeah. Again, she's got a valve in valve on that side. Yeah. So how much of that is what it should look like on echo at least, and how much of that is thrombus, is there calcification there, is something fixed, hard to say without having previous imaging to compare to.
Yeah.
But if you look at these pictures and you compare them to the previous case and look at the numbers and compare them. So here the TAPSE is almost half, right? Last study it was 17, here it's 10. Previous study, the S prime was normal at 10 and here it's 5. But do you think that the RV function is twice as bad in this case as it was in the previous one? I wouldn't say the RV function here is normal. I definitely would not say that. But I wouldn't say it's twice as bad again as the previous study. You know, adding weight to the idea that when you're assessing the right heart, you have to assess a variety of parameters and you have to contextualize the numbers to what the person is like. Because this is an outpatient. You know, she's like just toddling along at home, right? Yeah, so context is dependent. Again, he would come around a bit more to try and get a better look at what's happening to that right heart.
Yeah.
And at least see something moving. Bit of a drop beat there.
So look, yeah, we've opened up the right heart. You can appreciate that valve apparatus a little bit more.
Yeah.
You can appreciate, I suppose, the basal contractility of the heart is, I don't know, appreciably better than around at the apex of that right ventricle.
Yep. Not much more you can say than that, right? They're pretty dodgy images in a hard to image patient. Anytime there's a prosthetic valve of any description, I mean, you can sort of put TAVIs aside because they're different from a structural perspective, but you always want to try and capture whether there's, or consider, is there rocking or is there dehiscence or is there something like that? Does it look like that artificial valve in the orifice it should be sitting in? Does it look like it's properly attached? And here, I think they're just trying to demonstrate that it does not look like there is any sort of significant dehiscence or rocking of that structure. And you can see this, some struts in here and in here, and they don't look to be completely detached from the tissue around them with some independent motion from within that annulus. Here's just some measures. So in the internal diameter at the end of diastole of 6.4 centimeters, end of systole, I don't know if this I mentioned, just the diastole at the base there. So normal is sort of under 43 millimeters. RV size, it's massive, and fractional area change of 15%. So normal is, depending on what reference you read, so either greater than 32 or greater than 35%. That's profoundly below normal. All right. So come around again, just look at the IVC and get a bit of color once more across that tricuspid valve.
So yeah, on our subcostal again, we can see that stenotic inflow on the color Doppler there. Looking at the IVC on your image on the top right there, looks like there is, it's a bit hard to see, but at least a little bit of variation throughout the respiratory cycle. I'm not seeing, on those views at least, any prominently dilated hepatic veins. And down in the bottom, you've got a continuous wave, presumably at a hepatic vein there, and so there is a you have flow reversal, both at the endodiastole and start and endodiastole. There's little pulses of flow reversal there. The significance of that, I'm sorry, I'm still getting familiar with the Vexus type things.
Completely fine. So it's again reflecting the image quality. It's pulse wave as opposed to continuous wave. You can kind of make out the gate there, and these things, if you squint, they'll look a bit hollowed out on the inside, showing it's more pulse. Drew, Rishi, what do you make of this pulse wave profile?
Yeah, there looks like a reversal there.
When?
In systole. I mean, it's a bit of a delayed thing which is going on. Maybe it's stenotic. Maybe the pressure is not getting transmitted as quickly back. This is my guess.
Drew?
The color will be good across the hepatic vein. We can slow it down to see if there is a reversal there.
Sorry, I missed the whole context in the story.
So outpatient,
yeah,
who routine echo for her. She has a history of tricuspid valve replacement,
yeah,
and decades ago, 2 decades ago, 1.5 decades ago, and then subsequent to that, she had a transcatheter second tricuspid valve put in place. They did a valve in valve on the right side.
All right. So I guess we're looking at the hepatic vein. We're trying to assess the changes in it throughout the cardiac cycle. We don't have a respirometer to assess, where they are during breathing. You can see that last wave is increased. That could be during inspiration or expiration. So, probably the key thing is so the first. You can't see my pointer. The first wave is an AR wave or reversal wave. The next wave is an S wave.
Yep.
And then this is a S reversal wave, but which may be actually kind of a combination, like a reversal, perhaps not of the S wave, but of like a loss of the D wave. So if it was during inspiration or expiration, that might be helpful. And inspiration is in the presence of restrictive disease. Expiration is more in constriction. And then you can see that it kind of normalizes after that with a normal, maybe a slightly blunted S compared to D on the next
cardiac cycle.
Cardiac cycle.
Yeah.
So in the context of the patient, I guess we're using it to evaluate right atrial pressure. If we're thinking of maybe she had a pericardial. It was an open. One was a TAVI, one was an open.
Yeah, the first one was open. Second one was
so depending on her symptomatology, it could be something like a constriction. The respiratory cycle might be helpful, I think.
Yeah.
I don't know. Is that
so she's definitely had a pericardium open.
Yeah.
The first one.
Yeah.
And she's got no acute symptoms, to be clear. I'll be more precise with my language. So atrial reversal and then systolic and diastolic. You mentioned inspiration, expiration. So for the sake of people that are getting just more earlier in this process, why does that matter? Inspiration, expiration, in terms of this?
A fantastic mnemonic that I think Sam taught me was RICE, RICE.
Absolutely.
And so restrictive inspiration is when you get that reversal. And usually it's a blunting of the D and then that kind of more prominent AR reversal. And then CE, so constriction, is during expiration. And it's that same sort of process, a blunting of the D wave with a prominent AR reversal.
Yeah. And so just to be clear, so this is when you're doing a interrogation of the hepatic veins and you see reversal not in systole but in diastole, right? So you see systolic flow reversal in hepatic veins, systole, right? So you're thinking of significant TR. If you see it in diastole, then you think of RICE, and you think if the person's breathing in and you're seeing this profile, you think of restrictive disease. If the person's breathing out and you see that profile, then you think of constrictive disease. The sort of the physiology behind that is, I would describe it as complex, right? Because it comes down to what pericardium is doing, what interventricular septum is doing. So Lucas, this will become more and more clear. For me, it took me years, but I'm a slow learner. So it will become more clear, but recognize that for now. So I agree. I think this AR, I think it's our systolic profile, which is normal. It's flowing away from the probe. And I think there's a little bit of early diastolic flow reversal. What that means in the context of this valve, I do not know.
Is it because the right atrium is contracting against a stenotic valve and the pressure is transmitted back into the IVC and we're getting a reversal after the P waves in the diastole?
Do you mean for this?
Yes, I think there is some of that could be in different phases of the respiration, as Trey was pointing out. But considering in the clinical context, I will anticipate that if there is an increasing in volume delivered to the right atrium,
Mm-hmm.
and it's contracting against a stenosed valve into the right ventricle, some of that pressure will be
Backflow.
pushed back into the IVC or the hepatic vein. And
Yeah,
which
man,
will
absolutely.
clear it.
Completely agree. Completely agree. So same case, same patient. And this is their function now. I'm keeping an eye on the timeout to my right there. So I'll skip through a couple of things now. So her weight's come down, right? So she's not because she's been deliberately trying to lose body fat. Let me put it that way. She's just been more compliant with her regular diuretics. And I think at least that eyeballing the ventricles here, you can see that, in my opinion, I think that the left ventricular contractile function is greater now, allowing for the discrepancies in interpretation across color Doppler, of course, and we're not beautifully on axis here, but I think that this is suggestive that we have probably better RV contractile function here too. Just trying to capture some gradients across that tricuspid valve. Haven't measured a peak through here. So zoom in. So here, I think you can see this dome there better. And this is our tricuspid valve. Again, see some artifact coming here, but get these to play. So again, allowing for some subjectivity, of course. Perhaps the pictures here are a bit clearer. She's lost some weight. She's lost some fluid from that. I think that the RV function has improved a little bit purely through her increasing her diuretics. I agree that her RV function is, or I would say that her RV function is not normal, but I do think it's probably improved to what it was. TAPSI 1.1 S prime is 4. Again, horrible numbers. Comes again at ED. Same patient. Weight's up now. What do you think of these pictures? Apart from the quality being crap, because there's lots of artifact. Anyone want to comment?
Are these images after she has been diagnosed?
So she's come back in with her weight up now.
Weight up.
Okay. Yeah. What do you think this is?
It's part of the valve, something protruding into the right atrium. So some kind of it's like a mobile structure, which is like moving along with the cardiac cycle. Could be part of the valve, which is either disrupted or damaged, or could be a vegetation or a thrombus.
Mm-hmm. Or
a they suture the ring.
Yep.
And one of the RA anatomical structures that I'm forgetting the name of.
Or you can kick yourself.
Or the valve, is it just prolapsing into it?
Or you can kick yourself, Rishi. You truly are. It's like one word that you haven't said.
Flail or what?
Or artifact, right? Could be an artifact.
Okay,
It could be artifact. You can see certainly it's a single white reflector. It's moving synchronously, cardiac cycle. And so far, I've only seen one playing. Could be artifact, but completely agree, right? It's a person who's got history of two prosthetic tricuspid valves. You've got to think about those things you mentioned, especially if it's unwell, because of stenosis due to thrombus, due to pannus, due to infection, all those things you have to consider. Completely agree. All right, this will be my last one probably. This is a great guy. He's a fantastic guy. I don't think anyone here would have met him he's been able to stay out of the intensive care unit now. So larger chap, history of antiphospholipid syndrome. He's had a stroke in the past with no residual neurological deficit. And as part of his APLS, he had pulmonary emboli with CTEPH, chronic thromboembolic pulmonary hypertension, for those that aren't familiar with the acronym. These pictures are a bit dark on my screen. I'm not sure how dark they are on yours. Can you see cardiac function very well or not really, because the pictures are too dark? Not really? Okay. Let me move on here again. All right. What do you think? Subcostal views here is apical and parasternal short.
Severe RV dilatation and severe RV dysfunction. Can't comment on the thickness based on this, but there's definitely element of pressure overload. Could be an element of volume overload, which we need to slow down and see. Again, features suggestive of significant pulmonary hypertension with the IV septal flattening and the interventricular septal bouncing, which is happening. LV function appears to be adequate along with the size and probably biatrial dilatation.
Yeah, very hard to see the atrial well, isn't it? Like you can't see them at all here. You can kind of make out the right atrium here. You can't see the endatrial septum. You don't really know what's happening there. RV is clearly larger than the LV here in our subcostal fall. And you can just see that bounce. You can appreciate that abnormal motion of the septum. I find interpreting septal motion really challenging. I often want to slow it right down, and I do prefer to see it in a short axis rather than a long axis. I know some people are different to me on that. And then trying to work out why it could be there, of course, is a different story again. People often overlook the simple things. Don't forget to look at the ECG strip and see what their QRS is like, because that can give you an impression of abnormal septal motion. Moving on. All right. Rishi, do you want to keep going with this?
Yeah, pulse wave across the RVOT showing significant, very low pulmonary pulmonary valve acceleration time,
What's
along
normal?
with notching. So I would say 120. Less than 90 will be significant. So this is definitely significant. Looks like well optimized race, could be a little bit better in terms of the occupying more length of the screen, but the speed is good, and we have just one waveform. But it looks like a bit more fudged. We don't have the modal velocity measured, but still looks like significant with notching, which is more suggestive of precapillary pulmonary hypertension, along with a reduced S prime, all in keeping with significant RV dysfunction,
Yeah.
along with possibility of precapillary pulmonary hypertension.
Yeah. BTI of 11.4. Then here you can see, the notching is there. It's a bit slurred, but it's there. Kind of a measure attached to your eye. You couldn't even see well enough. So he went down and had a pulmonary endarterectomy. Very rocky course down in Melbourne, but got through, thankfully. Those pictures may not be very good. Dark again. Can you make out much here, Rishi? It's a bit dark.
Yeah, can't make out from the parasternal long axis. Still, there's continued evidence of RV dilatation. The function appears a bit better, but still very difficult. I can't see the lateral wall well.
Yep.
Still, there is persistent interventricular septal flattening along with the bounce. Yeah.
Yep, completely agree.
It's good. IVC appears collapsed, but with respiratory variations, probably well diuresed at this standpoint.
Yeah.
RV is handling the volume well. LV function is normal, but RV is definitely still persistently severely dilated.
Yeah.
Needs more time for remodeling.
Yeah. So he had cardiac MR done as well, and his overall RV function post PEA improved a little bit, not drastically. Interestingly, after the surgery, though, his pressures came down and his resting oxygen saturations went from sort of 85, 87% on room air to mid-90s on room air. So his ability to oxygenate improved drastically. VTI has come up a little bit, 12.8. TAPSI is only halfway normal at 8.5 or 9 there, and S prime's still a bit down. He's lost, we're not completely lost his notching. It's still a bit there. Acceleration time, though, 100. I've got 1 or 2 minutes left, so I'll just do a quick touch on pulmonary pressures. Some of this most of this will not be new. I appreciate that, but I think some of these fundamentals are important because we often use terminology probably a bit more loosely than we should, or we misinterpret some things. So fundamental stuff, what we really want to measure is we want to know what's happening across the whole circuit, right? And we can't really measure all of that, but we want to know what's happening in our pulmonary arteries, but we also kind of want to measure what's happening in our pulmonary veins, especially when we're doing things like trying to make estimates of left atrial pressure. These are some of the formulas that exist that are out there. Certainly a lot of them are not regularly used. Obviously, this here is used all the time, right? Generate some right ventricular systolic pressure estimates. Anywhere, depending on what you read, from 20 to 30% of patients with significant pulmonary hypertension will either miss or just not be able to see their tricuspid regurgitation jet. So a negative echo, negative in the sense of no TR seen, therefore assumption of a normal RVSP, is not a clearly definitively negative test. The other formula that's thrown around a little bit is this pressure up here. So this one up here, where your mean pulmonary artery pressure is 79 minus this, and this is where the number of 100, that magic number of 100, sort of makes the maths easy, and you can work backwards to work out what the estimated mean pulmonary artery pressure is from there. Remember that a lot of the, or not a lot, like the definition of pulmonary hypertension, right, runs off what your mean pulmonary artery pressure is, not your systolic. It's a common mistake. People look at the right ventricular systolic pressure on an echo report, and they apply that number to data derived from the mean pressure. Notching, so we spoke briefly about notching on that last case. So notching is that blip in the upward stroke or the stroke back towards the baseline during systole, when we've got a pulse wave in that pulmonary artery. And it's a premature reflection of that systolic wave. We associate that with having an obstruction. People think about that with like PEs, for example, but anything that causes stiff pulmonary artery vasculature. So yeah, pulmonary can cause that. A word of warning, alignment is really important. If you align the gate so it's right up against the lateral aspect or the side, you can get changing your notching pattern because you don't have good alignment. You can also get it can change your clicks, of course. And I'll finish up with this paper, because it's actually a good one to go back and read if you haven't got a good grasp of some of this stuff, because it sort of goes through some of the physiology of it, to the best that we can assume it happens at least. So it's not a huge number of patients, 88 patients, right? And they took them from a clinic, all had PH, and they put them into sort of these 3 groups: no notching, a mid-systolic notching pattern, or a late systolic notching pattern. We classically think of the mid-systolic notching, but there is also late as well. And here's, they did some invasive stuff with them. And here's sort of what they showed. They showed if you don't have any notching, so this is your here's our pulmonary artery wedge pressures, and here's our resistance. So no notching at all, you're going to have pretty low pressures. Mid notching is here, and high notching, mid notching is here, and late notching is there. So you can see what tracks through within the low, mid, and high pressures, and then also our resistance to our Woods units. If you've got no notching, you're going to have low. If you've got mid systolic notching, So the black line, you're going to have mid elevation in your PVR. If you've got mid-systolic notching, you're going to have a high elevation in your PVR. So the percentage distribution there. Because we sometimes throw around the phrase of notching does not necessarily equal raised pulmonary pressures. It means raised pulmonary vascular resistance, as Sam likes to throw around. And I suspect that's derived from this paper, because this is really what they were demonstrating. You've got mid-systolic notching, you've got raised pulmonary vascular resistance, not necessarily raised pressures. Yeah. All right, I think I'll stop there because it's 3 o'clock.
Thanks so much.
Shrink this back down. No worries at all. As you can see, I did have more slides, some other cases towards the end. Again, so for those of you that are just joining or rejoining the program of going through some stuff with the DDU teaching or EDEC teaching or ASE teaching, welcome. Ask questions along the way. It's going to be a full series of lectures. Bring cases if you've got them, bring things to talk about if you've got them. We prep for the exams, but just because we prep for the DDU exams does not mean that we don't cover stuff relevant to all the other stuff, all the other exam sets as well. That's it. Drew, got a question? Shoot.
Given your background in respiratory medicine, I'm sure you've seen your fair share of really blown out RVs, dysfunctional, and I'm thinking of like your OSAs, obesity hyperventilation syndromes. Do you find when they come in quite congested, I guess one of the first things you want to do is diurese them. Do you ever, what's your, I guess the approach to management is my question. When do you feel that is it purely clinical when you decide that you've effectively diuresed them? Do you use any ultrasound parameters, acknowledging the fact that maybe they do need a high preload given their RV dysfunctions? Trying to diurese them to an RAP of 8 might actually, reduce their stroke volume and things. So is there anything that you in your practice use to kind of guide diuretics in these patients outside of weights and clinical parameters?
So I'll speak for the group that are not on positive pressure ventilation, not invasive positive pressure ventilation anyway, because that's a different kettle of fish, I think. And I think Sam, for example, or Emma would be a better person to answer it in that context. I can speak for it when they're not in the intensive care unit. So I will classically go by a few things. I will go by clinical. I'm trying to incorporate more into my practice the idea of doing regular, effectively peripheral ultrasound, right? So yes, I like to have a quick look at their heart. I'm very fortunate in that I've got a GE venue up on the ward with I've got a cardiac probe, so a phased array probe, as well as an abdominal probe for that. So I can just have a bit of a play and a bit of a look, right? So I'll go by IVC. I don't do a full Vexus approach on all of them all the time. I probably should, because to be honest about it, it's not that hard. It's just that I'm lazy. So I'll go by their clinical features. I'll go by what their IVC and right heart looks like dynamically when I'm taking pictures of them. And that's just bedside poker style. Even though we're talking about right heart dysfunction and overloaded right side, I'll still always have a bit of a look at the lungs, looking for just a number of B lines, because I still find that useful, even though it's at a different point in the circuit, right? Because it's just that relationship between your left atrial pressure, is that up because of your high right heart pressures? And if you back off those right heart pressures, you decongest the forward flow. Like if you can pull that RV that's probably potentially too overloaded, it's gone off the edge of the Starling curve, it's overstretched, you diurese them a bit, you get a bit better contractility, and you can pull some stuff out that way. So I do have a bit of a look at that as well. And then I also, biochemically, right, I use BMP a bit. I wish that came back more quickly. But I think there's, again, looking at left heart stuff, there's very good evidence, I would say, about prognostication and tracking of BNP. And I use probably inappropriately, at least partly translate to the right side. The delay that you have with that, though, and getting the result back can be the problem, because if it's a sort of test you got back within a few hours, happy days, you can do it every day and see. But at Nepean, we don't get it back the same day. I don't know where it's processed, because some days it seems to come back like that night, and other days it seems to take like 4 days, and I have no idea why. So it's on the list of many things I need to look into. But yeah, I go by clinical, and then I go by what their right heart and IVC look like. And I'll have a bit of a look at the other vasculature on the right. So renal, although they can be hard to see, those vessels, especially in the bigger patients, and then biliary tree and stuff as well. It's my approach to it.
Oh, thank you.
The other thing that I find useful as well, I mean, yes, we all track urine outputs because we're diuresing these people, right? But I track what their sleep is like subjectively, right? Like, what are you sleeping like now? Is their sleep getting better, and is their compliance with bi-level or CPAP, depending on what they're on at baseline, if they've got OSA, of course, or OSA, OHS, depending on what they're using. And I find that, again, subjectively, like, the quality of sleep just improves to a certain point. But then once they're up and about on their feet, I'm like, you're a good man. If you can get up and walk around, you can walk yourself to the bathroom, go home. Yeah. If that gives you a bit of an answer. I find it hard because I think some of these patients you can get, especially again on a medical ward, you can get so caught up in trying to optimize everything, which is great, but then you become resource limited. And you're going to spend days trying to optimize all their little things, their bi-level settings, for example, if they're on nocturnal bi-level at home. I'm not saying it's not important. It is definitely important for outpatient long-term care. But I run out of patience, like not the person patients, the internal patients for that. Don't get them good enough, and then go away and come back to clinic. Ideally, someone else's clinic, because I don't really like sleep medicine very much.
Yeah.
Because it's 95% OSA, less than 1% interesting sleep disease, and then the rest is arguing with people why they're not allowed to drive. Truck drivers.
Bad news clinic.
Yeah, exactly. Yeah, it's you can't drive, and you can't drive, and you can't drive, and you can't drive, and you're all truck drivers. Sorry.
Yeah.
Oh,
thanks for that.
No worries. All right, so that's the end of it for today. Thank you, everyone. See you next time. Again, for people, share this around, please. Share it on the YouTube channel. The more people we get, the better. Bye.
Thanks, man.